Good morning, everybody.
Good morning, Tejas. How are you?
Good. I am, welcoming you all for the 16th edition of this course, which is no more a transradial intervention course. TRICO, the acronym remains the same, but now we have changed the name as transcatheter intervention course, and we are going to, as like every time, we want to, add lot of new things, and structural and imaging part we are going to show this time. Imaging and physiology we are going to discuss very frequently. First of all, I welcome you all my international guest friends who have taken pain to come here for this short duration of 2 days by traveling so long and taking time out from this extremely busy schedule. I am also grateful to all my national guest faculty friends again for making it like every time and honoring us with their presence, and all my dear participants who are coming all the way from across the country, each and every corner, as well as my very dear Bangladesh friends who all the time come over here, and I love them a lot, and they also, I know that they also love me a lot. And uh, we have most of the faculty, the same, like great Dr. Shigeru Saito is here, who has been my mentor, my and Sanjay's mentor for transradial. And then we have Samir Pancholi, very dear friend since more than 4 decades, and again Tak Kwan, John Kapola, Rajiv Gulati, all very dear friends, and Dr. Akasaka, who has been our mentor for all our understanding of optical coherence tomography and imaging, and again Fazila and Mir Jamaluddin, very dear friends, and all other important, Sabina Hassan, Amal Kumar Chaudhary, and all other Bangladeshi guests. I welcome you all. And Elvin Kedi is a new addition who has been very kind to come from all the way from Belgium, and he is academician of very high standard, and also a very accomplished operator. We have Dr. Lars Sandergaard coming tomorrow morning to show a beautiful tower case, and I will request all young generation of this country and Bangladesh to come sharp at 9 o'clock, because he will be showing the case tomorrow at 9 o'clock. And Sanjog Kalra is also coming tomorrow from Toronto General Hospital. So having said this, I think we will quickly start our case. Samir, I hope international and national guests have already come on the dais, most of them.
Namaste, sir. Dr. Amol from Bangladesh.
Namaste, Amol. Thank you very much.
Along with Fazila and Mir Jamal and Sabina, and our doctors are sharply come at 8:30, sir.
Thank you.
20 or 25 doctors from Bangladesh.
Yeah, thank you very much.
Thank you, sir.
Yeah, I think we are all set here, Tejas.
Yeah, so Aman is going to...
Good morning, everyone.
Yeah.
So, case number 1 is a 63-year-old female, a known case of diabetes and hypertension, who presented with NST elevation ACS, has a normal LV function, and angiogram revealed left main bifurcation, Medina 111, 90% stenosis at distal RCA bifurcation, that is also Medina 111. We also have a lesion in mid LAD, and syntax score is 17. So the plan is RCA bifurcation stenting followed by left main bifurcation stenting and mid LAD stenting under OCT and or IBUS guidance. Over to the cath lab.
So with me is my colleague and my partner Dr. Sanjay, and the new addition is as a cardiologist is Aman Patel, and as usual Dr. Rajni, who is also with us in the cath lab. Dr. Rajiv Gulati and Dr. Akasaka are going to be the on-site moderator to make the things very interesting. You can see the right bifurcation, and PLV is also pretty big. So just go through the angio, yeah, and yeah, and left main. Just run it please. Yeah, very tight distal left main and LAD. Over here we have a very vibrant left main bifurcation stenting program, and practically, you know, we are doing this type of cases every alternate or third day, and so many of them are being referred to us from every corner of this country for this type of cases. And now, Rajiv, what do you think? It is in the guideline for experienced operators.
Absolutely. Yeah, absolutely, Tejas. This is a fantastic case to start the sessions. What a great honor to be back at TRICO. What a great case to start. It's in the guidelines. Now, my question to you, Tejas, is your choice of order. Are you going to choose the right first or the left main first, and your reasons for doing that?
I am going to choose the right first. My strategy will be, because right is a pretty big artery and a very supportive artery also. So my strategy will be, you know, provisional T for the right. And once it is done, I will, you know, evaluate under, you know, with OCT imaging. And for the left, you know, we will be using a 7 French guide, again left main bifurcation stenting, and my gut feeling is I think we should get away with provisional T rather than going for you know, mini crush. In our lab, we are practicing these two techniques for bifurcation, either provisional T or mini crush. The data, the European data is very, very, you know, supportive for provisional T, right? As far as the long-term results and TLR and MES is concerned.
Yeah, absolutely. I mean, there's still so much variability in how people how they handle bifurcations. I think left main a tendency now is to do more complex with DK crush and other data, but you're absolutely right. The European data does still support a provisional approach. Dr. Akasaka, maybe Japan, provisional or 2 stents?
Yeah. No, Japanese physician like to do the provisional stuff.
Provisional, yeah. So I think that makes a lot of sense. Here, you know, I want, you know, the camera to be focused here. This is a slender 6-7 sheath because I am going to use 6 French for the right and 7 French guide for the left, right? And this is, you know, a default technique. This is a combo technique, modified mother and child technique, a 5 French long multi-purpose catheter, and over it is a JR guide, Medtronic, and always as a default strategy the wire is baby J. Just show, Sanjay. This is a very beautiful, you know, little tiny tool from Terumo, and which has been of great help, and it has, you know, it has been instrumental to reduce a great amount of local complications and hematomas in our lab. So this is a default wire for us, baby J. So this technique has been published by us in cath cardiovascular intervention way back, maybe before 7 or 8 years. Balloon assisted tracking also, you know, has been described by us, but balloon assisted tracking we are using very sparingly in extremely difficult cases. Okay. Elio.
So Tejas, I noticed you had a radial angiogram. Do you still do that routinely?
No.
Access?
Whenever I want to use a 7 French guide, like I am going to use it for the left, so we make sure that the radial is straight and is a reasonably sized radial, not for regular in every case.
Good morning, Tejas, Dr. Jayesh Prajapati.
Good morning, Jayesh. Thanks for coming.
Oh, my pleasure.
Thank you.
Yeah. Just I want to ask, what do you see the future of dedicated bifurcation stent in current era, like in RC bifurcation or LED diagonal and all?
Jayesh, bifurcation dedicated bifurcation stent will have a trouser and two arms, I suppose. And in how many of them we are going to use? And I personally feel that less the metal you use, it is always better for a patient. And particularly in bifurcation situation. Of course, with availability of Brilenta and Prasugrel, all those problems of instant, acute and subacute thrombosis has gone down reasonably. But I still feel that if I feel very strongly that I can get away with provisionality, I will not go for double stent technique. Sanjay, what do you think?
Agree.
Dr. Patel, another question for me.
Yeah, Elvin,
Actually,
good morning.
Good morning, and thank you. I have two questions. The first of all is this technique is very interesting, having a 6 French and then switching I think the 5 Frenches through that. That's the idea of the technique?
Yeah, because this reduces lot of injury on the radial, particularly while we are tracking, because very old patients may have calcified radial, they have some tortuosities, and like pushing the guide catheter straight can give some razor effect to the endothelium.
It avoids all the problems you can have with spasm in the arm. And yeah, very, very good. And the second question, coming back to the case now, it's first of all, you have Dr. Akasaka right in your back, and I think he's there for a reason. I think that you are about to use imaging during this procedure. And how will you tackle it? Would you do it just before, after, and what kind of imaging? And and my question is, I'm triggered of what you think of that second bifurcation of the LED. Is it a bifurcation or just a middle LED?
That is mid LED, because anything 2 millimeter or less as a side branch, I am selectively blind. I will not think it as bifurcation. What do you think, Rajiv?
100%. I remember somebody told me with angioplasty, the main thing is to keep the main thing the main thing, and anything less than 2 millimeters is I ignore as well.
Go to aleocranial. Take aleocranial. Come down.
So Tejas, quite a size mismatch here between the. Oh, actually, maybe not. So you're going to stand into the PL or into
Of
PD?
course, PLV is huge. You want any other view? I think I am very comfortable using this aleocranial. You want epicranial? Not needed. 2 wires. Our default wire is run through extra floppy.
Yeah, I think there are only a small, minor discussion about the RCA bifurcation, right? Which direction to put the stent? Initial stent is
it is going from RCA to PLV.
Yeah. If the size is very similar, I agree, because it's quite easy to pass after putting a stent.
So this is what I feel. The young cardiologist, we have, I will just discuss the wiring technique for bifurcation. I personally feel that always wire the complex branch first and then wire the straight branch, because if the wire goes in the straight branch first and while wiring the complex angled branch, if you do too much of rotation, there can be entangling of the wire, and that can create a problem while you are pushing a balloon in. So as a part of that strategy, I am going to wire PLV first. Scout.
Why not 7 French guide for RCA? You have got 7 French access.
No, because I am sure that I am not going to do 2 stent over, mini crush over here. So if provisionality is required, then I don't think it is needed. This wire is giving me some problem entering PLV. If it doesn't, then we might have to change the shape, I suppose. Let me see. Let me try it out. Okay, Scout. No. Or we can change the view. And the third thing oh, it has gone. The third thing I could have done was to dilate it and going through that dissection. But that I will not recommend, the beginners. No, because then sometimes you can get stuck.
Sir, good morning. Dr. Pintonata here.
Oh, my friend, how are you?
Sir, fine. Sir,
Tell
I
me.
want to know about taper stent because your PLB and your RCA. So
That's a very, very, very good question. What I will do is I will go at around 10 or 12 atmosphere to start with, and then I can pull my balloon back and go at a very high pressure because the proximal is very big. I may require to do some pot also in that region.
tapering stent is available or?
Tapered
Tapered
stent,
stents.
we are not using. I think one of the companies is making, but somehow we don't use Scout.
Okay.
The Merrill was making, but they have stopped. or
Acha, they have
somehow.
stopped?
Yeah.
What you're thinking here, what about the anticoagulation and antithrombotic strategy for this diabetic patient with multivessel disease?
Yeah, see, Brilenta we have loaded with aspirin 75 milligram, and my personal practice, both of me and Sanjay, we give Brilenta for 4 months and then we switch over to aspirin clopidogrel. Because we feel that at the end of 3rd month, by and large things are alright, so 1 month extra. It is not in the guideline, of course, I know that. What is yours?
So we moved away from Brilinta back to clopidogrel. The US have a different, financial atmosphere. We had a lot of patients who couldn't afford the Brilinta after 1 month, and so would stop their medication. And we had so many problems that we decided to go back to clopidogrel as our main, as our primary antithrombotic agent.
But how about then using prasugrel? It should not be as expensive, or it is also.
You're right. Prasugrel is cheap. It's generic, but with the contraindications, I think so few patients.
Yeah, that's right. Yeah,
are
old
eligible
patients.
for that.
70.
More recently, we've moved to genetic guidance. Now we did Taylor PCI, so we're doing genotype testing and deciding on antithrombotic that way.
2.5 we will take, no problem.
And Tejas,
we'll
heparin here, 70 units per kilogram heparin.
Yeah, but normally, in an adult who is reasonably well built, we give straight away 15,000 unit. Because I tell you why. Because somehow I personally feel that in this subcontinent, the arteries are quite thrombotic. So I like to keep, the INR at the end, ACT at the end around 350 or maybe little higher for time being.
And that's very interesting. Does it affect your hemostasis with the radial?
Not at all. Not at all.
I think that's a good thing about it. If we were in the valve situation, that would have been a different thing. But being in a radial situation, I think it's defendable.
And let me ask Dr. Akasaka, so with a very tight lesion like this, you couldn't do OCT because there'd be no contrast. You'd have to dilate first?
Yes. Yeah. We often use 2.0 or 2.5 pre-dilatation if you want to get a good image. But even if it is tight, sometimes we use a saline injection because viscosity is low. So and especially RCA branch is less than LED. So saline injection is sometimes useful, right, for RCA. Yes.
Balloon?
아이고.
Go to LAO. We'll be able to see balloon properly because here the diaphragm is coming in my way. Yeah. Okay, go. No, keep it this way only. No problem for time. 6, 8. Oh, slipped. It slipped. Come. Wait. Yeah, inject. Go here. We see there is a tendency to slip. So what we will do is we'll go on 3 or 4 and we will allow the balloon to stabilize. Now it has got here. You can go at 12, 14, no problem. 14. Come down. Fine. Okay, now go to LAO cranial.
Remove.
Yeah, just let me wire the PDA. Fine. Okay, this is good. Inject. It looks nice. Huh? So, what is going to be the stent size? I am not going to use anything longer, although there are some irregularities distally. I don't want to load this patient with lot of, because they are all insignificant type of
We
lesions.
get nitro.
Okay, we will give nitro, no
Yeah,
problem.
Exactly.
And concertina
So
also.
we get the exact
There is
size.
some concertina, that's right, Sanjay has noted out. 2.5.
Dr. Tejas, good morning. Rajesh on this side from
Oh,
PPH.
how are you? How are
I'm
you,
fine.
Rajesh?
Thank you.
Thanks for coming. Thank you.
My pleasure. Dr. Tejas, will you like to do some imaging to look for the size of PD and PLV before
Wire
putting
is
the
out,
stent
yeah.
across?
No,
Acha,
inch,
yeah.
deep inch.
Batao man.
It is
Yeah,
deep
imaging, in this case, I could have done that, Rajesh. Just show me the distal tip
Distal
of
tip
PLV.
PLV.
See, this is, no, wait
little-
a minute.
little bit.
I have to come out. So all my fellows and the young cardiologists who are working with me, this is one advice I always give. You have two eyes. You know, if you want to avoid most of the complications in the cath lab, your one eye has to be at the tip of guide wire and the other eye has to be at the tip of guide catheter. And you will be fine with most of the cases, because these are the, problem. Acha, now regarding Rajesh's question, here, because in left main bifurcation we are going to take some more time, so I will be using a short 2.75 by 12 millimeter synergy over here. And I will tell you the reason why I am going to use synergy in this case, because that stent, I personally feel that it is one of the very nice stent for differential expansion. Again, I need some comment. Samir, what do you think?
Yeah, I don't have much experience with synergy per se, so but I think you've used it a lot, and you need differential expansion here, so
Yeah.
that would suit well.
What do you think, Rajiv?
Yeah, no, it expands well. If you look at the chart, the 275, you can take up to 3.5 without any problems at all. I think it's a great choice here. Other stents are pretty expandable too, but I think Synergy is great. Just for those in the audience who are from the US, the magnification here I noticed 15 centimeters. In the US we're 20 or 22, so I look at this and it looks like a 4.0 stent. But your eyes with a different magnification it's very hard to get used to.
See, Indian arteries fill very bad very fast, and they are very complication prone arteries, so we are careful. In any case, we are going to do OCT imaging and we will accordingly decide, but I am not going to go to that 4 area, and that's the reason why I am sticking to a very short stent.
And do you think that short length is adequate for a pot? It should be, right? It should be adequate to post-dilate proximally.
I think so. No problem. Because proximal, Rajiv, is pretty big, and I will post-dilate with 3 and not more than 3. And with 3 also, I am expecting, negative residual in the proximal part.
And then Tejas, your strategy, if the side branch looks okay, you're not going to do routine kissing, you will just accept a good side branch result?
Because after doing so many OCTs, our understanding is OCT will bifurcation software will very clearly show the side branch status, and many times you see a hardly any stent strut hanging maybe on the side, and the lumen looks good. In that case, I will not disturb that lumen. Yeah, inject.
I agree with this, and the more you do it, you see that often you don't have anything in the side branch.
Here I will go on 12. 12. Keep it for some time. Deflate it. I will come back a little bit. And you may go high here. No, that's it. I. I will. Okay. 18?
18.
At 18, it becomes 3 internal diameter, 3.06. Okay, that's great. I am pretty sure that we might not have to even post dilate. We'll see. OCT ready? Look at this. There is some plaque shift, but this seems to be very acceptable and we will be able to see that.
And let me ask Dr. Akasaka, so can you distinguish plaque shift from carinal shift easily on OCT of the main branch?
Yes, if we have pre-PCI image, we can speculate the carina shift. It depends on the angle of the carina and also the length from the tip and the bifurcation start, right? If it is more than 7 millimeter and angle is less than 50 degree, we may have a risk to carina shift, yes.
Dr.
Yes.
Patel,
Yes?
for the younger colleagues, I like to add one sentence here that to pull back the stent balloon and go to the higher pressure, we must have to be confirmed that proximally there is no plaque.
That's right, but
Proximal
the artery
segment
is
should
very
be
big.
healthy.
Yeah, I agree, absolutely.
Yes.
But I can see that the proximal artery is around 3.5 or even little more than that.
Yes.
So that's why I was pretty confident doing it. But I agree fully. If there is a plaque, you are dissecting it.
Yes, sir. Thank you.
Just I want to ask, this 2.75 stent, we go to the 4, what amount of foreshortening you expect when we have taken at least the same 12 mm like that and expanding more?
Yeah, foreshortening problem, we have seen and we have appreciated clinically more in bigger stents just maybe 3.54 or 4.5. I need to know, the opinion from others. Rajiv, what do you think?
Yeah, the foreshortening, it's an important point. We worry about it, particularly in the left main, when you have a 5 millimeter donor and a 3 millimeter recipient vessel. In this sort of vessel, I don't think the size mismatch is that bad. I wouldn't be too worried about the foreshortening aspect here. But you're absolutely right. It's an important point to bear in mind.
Just at the edge here, stent distal part है जैसे.
Because it's a left main, it's a big issue. When we implant a stent, when we post dilate 4, then stent becomes shorter. So we will end up sometime with putting another stent.
I think so.
Okay.
Yeah,
Just check it.
I agree, although it's unusual to have to put a second stent, but I agree it's a very important consideration.
Sure, I'm ready. Okay.
Inject. Nice. Now, Dr. Akasaka will give the commentary.
Thank you. Wait a moment, just pulling back from the distal site. Yes. We have lumen profile, right? Here is distal edge, no dissection, right? A position is very good, and the diameter is about the 2.7, right? And then here is the bifurcation, right? Yes. And this is the proximal site. Yeah, a position is okay. Small dissection, but it's already covered by stent strut. So try again.
So the proximal and distal landing also looks good. It is not in the fat. I am worried only if it is in the fat. If I get normal segment, I am very happy, and I am not unhappy if it is in fibrosis or sometimes in a short calcified area. But now I need to see the bifurcation, software.
Right.
Yes, bifurcation.
Here is in the bifurcation, right? Open very well, right? Only one strut here. try to see the 3D reconstruction, right? Bifurcation, right? Okay, right. Here is the main wire, right? And this is the wire to the yes, side branch. Only one strand we can identify.
Yeah, and
here,
link-free
right?
carina, right?
Right.
Link-free carina, it may be proximal crossing, but it's a link-free carina and a good area.
Right. Yeah. Generally speaking, yes, good. Yeah, the side branch opening is very wonderful, right?
So
Yes.
my question to you, everybody, I mean, in the faculty, moderators, that what will you do? Will you go for kissing or not?
So what's the MLA of the stent? This is a 275, and so we would expect about
275 is around 6.
6. Yeah, 6.
Yes.
So what's the MLA here?
MLA distal portion is around 5.6, right?
And
Yeah.
proximal is,
Proximal, it's a little bit small, right?
because proximal is confusing with a big proximal segment. Samir, the bifurcation, software, and particularly these expansion software sometimes confuses, this thing and gives a wrong MLA, because if there is a tapering, sudden tapering, they may, try to compare it with a big area, big diameter proximally. Dr. Akasaka, what do you think?
Yes,
Otherwise?
yes. And the proximal, the size is 3.0 or 3.1, right? In the proximal side, that might be enough at the moment.
Yes, yes.
And we can identify the position using this color bar, right? White color is position is very good, right? Only red color demonstrate the incomplete position more than 400 micron.
More than 4.
We cannot identify.
This is hardly 150 or 100 mics. So, what do you think, Samir? Will you do kissing or not? Rajiv, will you do kissing or not?
I think, kissing wise, I would stay away. I might put a non-compliant 8mm balloon and go to higher pressure in the middle of the stent, because on the OCT in one of the angulations, it looks like there is a little hourglassing of the middle.
But I personally feel that I will not do anything here, because we have burnt our fingers sometime. By doing this, we are shifting the plaque, and then we are compelled to do kissing balloon and then one more stent.
That is true.
So,
that is true.
Yeah. So this is our strategy. So with confidence, I am going to remove everything. And this I do because I have done OCT. If I had no OCT access, I would have gone for kissing balloon, epicranial.
So Sam, if you were going to do a post-dilation, would you pull the jailed side branch wire and rewire first, or would you post-dilate over the jailed wire?
I would pull the wire if I was going to aggressively dilate.
Okay, go to LAO. Yeah, go to LAO.
That looks very nice, by the way. Yeah. Even expansion angiographically looks very good.
I think at the time of the bifurcation lesion treatment, the discussion is sometimes focusing on the side branch, but it is very important to focus on the main branch. Main branch treatment should be the most important. So we have to pay attention to the result of the main branch first, right?
So, Dr. Akasaka, what would be your metric or measurement to go after the side branch? At what point will you say, I recommend going into the side branch with a balloon and more?
Yeah, it's a very difficult question and also the wonderful question, important question. I think, yes, if I try to pass the wire through the strand to the side branch, we will try to pull back from the side branch to the main branch. But if we just get only main branch image, we just focusing on the result of the side branch condition, and there are lots of strata on the surface of the the orifice of the side branch, we think about the kissing balloon, but it depends on the stomach condition, right? If you try to, if the link free, and it is easy to pass the distal cell, we can do the kissing because it's quite easy and the result is acceptable and ideal. However, if there are a link and if we can only select the proximal site, there are a big problem. If you dilate the proximal site, stalagmite goes up to the main branch, right? That is the big issue. So.
Yep.
Tejas, can I ask you a question about radiation? You used to use a lot of robot, and does that mean your radiation protection now? I don't see shields, and you don't wear a hat and glasses. Has it changed? Because
No. Since last 32 years, we are doing the same way. Robo or no robo, it has not changed. But with robo, we are not wearing even the lead, because of the technical snag in the machine. We are not going to demonstrate this time, but otherwise there as a primary operator I will sit in the console without any lead. Now this is, hooking this, we will be very careful. I will take the stiff wire, the opposite end of a 35 wire, and try to open up the curve and very carefully hook the left main.
I just want to say one side note is that, Tejas, we've been to labs all over the world, but this is the most efficient lab in the world. It seems like your team know what you want before you know what you want.
Dr. Patel, here you are showing two important techniques to the younger colleagues. Yeah. Number one is 6 in 7 or 5 in 6. That is your routine practice, and we are also doing.
Yeah, thank you.
And for putting the guide catheter into the ostium, using the hard end of the wire.
Very carefully, this is the hard end, and very carefully I will rotate. Scout. No.
Here for the younger colleagues, it should be remembered that this hard end of the wire should not cross the tip of the guide catheter.
Go to first view I will take is epicaudal. See, why I take epicaudal as a first view? Because I want to confirm my coaxiality of my guide, Scout. Coaxiality is perfect.
Yes, it is once again very important to avoid the dissection of the left main for the younger colleagues. All for all, even for us.
Okay, good. And then maybe one epicranial.
So is it a trifurcation or a bifurcation?
Again, it's a 1.5 millimeter artery in between, so I don't see that. Okay, good. Now go to LAO caudal and we will wire it.
So Tejas, here are you going to use IVL, or what's your strategy for left main to LAD?
Yeah, I will aggressively dilate with a non-compliant balloon there. Here, we can take, one OCT run before.
Yeah, I think that will be ideal.
And Tejas, your experience of OCT versus IVUS for bigger left mains?
It's a good question. I am using now, since last 20 left main bifurcation cases, we have started using both OCT as well as IVUS, because OCT gives excellent idea about the side branch circumflex territory origin, and IVUS gives us a great idea regarding the ostium and whether to pot or not to pot or what. I need to give some curve. I want to wire the circ first.
Okay. Need to give more curve.
Go to epicaudal.
And Dr. Akasaka, in Japan, OCT for left main, IVUS, or mixture?
Yeah. The distal left main bifurcation, we prefer to use an OCT, but it depends on the institution, right?
You have to give the shape.
Left main orifice is one of the discussion, right? But we have some technique to see a left main orifice by using OCT. if you use an extension catheter like a Medscape, we can see the left main through the extension catheter, or some other colleague try to put the wire to the aorta, other wire to the aorta, and try to put the guiding catheter very close to the orifice as possible as we can, and then we get an image. Yeah, but it depends on the size of the left main. Yes.
Dr. Patel,
Yes.
is there any rule to do IVL or rota in this particular case? We consider which things is the calcification or bifurcation, left and bifurcation.
No. I will go by Japan calcium, the calcium score index for OCT. I think Dr. Akasaka has done original work on it. If I find it high, then only I may think of doing it. Or calcium thickness, if it is in significant area of it, if it is higher than 500 microgram, then only, not otherwise.
But in common consensus that left main IVAS is better than OCT. What about your opinion?
I don't agree completely with the guideline, because this is these are the Asian arteries, and most of the Asian arteries have left main diameter not even more than 4. So I was OCT can visualize very well up to 4.5 or 5. So not very few cases that's a problem, but and that we have realized even after doing this thing. Yeah. So now Sanjay is giving a very special shape for it, and I am very insistent on wiring circumflex, because if wire LED and then try circ, it may be sometimes again a problem while pushing the balloon. So he is giving a shape here.
So after imaging and pre-dilatation, what strategy will going to be adapted?
Again, in this case also, it is going to be provisional T and not 2 stent to start with. If need be, I will put another one at circumflex, but not otherwise. Because the angle of LED and circ is pretty wide. So even if there is some plaque shift, it should not be enough. And if need be, we will do even FFR. We'll see.
And then take decision whether tap or say provisional stenting.
Dr. Tejas, are you going to correlate the FFR value with the OCT area of the ostial LED and also the distal one?
That's a good question. That's a very good question, and I don't have a precise answer for that. If you have, you let me know.
See, I see though there is a calcium, the ostium, the LED, and distally again there is some disease in the distal LED. A functional assessment of the distal LED is required, and of course an OCT wise area of the
not about distal LED. Distal LED, we will not do that, no.
Okay. Here again, the ostial LED area wise, I'm not sure, but then seems to be good enough. FFR may be negative, the ostium of the LED.
But then we have to fix the ostium, because we are going to fix the left main. LAO caudal now. This is giving me hard time.
Here is challenging for crossing into the left circumflex.
Out. I will go inside LED.
Yes.
Come back, try to unfold it, scout.
What wire are you using?
This is a run through extra floppy. Sanjay, this is not working. Huh? Get another wire.
Yes, sir.
Any suggestion? Sanjay has given a curve which seems to be a little more acute.
I think a new wire would be
New wire.
Usually when you ask for a new wire, the first wire works.
either that or pilot 50
Yeah,
with,
that
with,
can
with a
change
flying
the
cross.
direction.
Suppose it's a calcium, what kind of disease, lesion modifying technique you think?
Let me see the OCT evaluation we will do, and then we will decide. Sanjay is giving a little bit of lordotic curve at the wire apart from primary and secondary curve. Okay. Just show the curve. Okay. Chal.
It looks like AL. Huh?
Yes.
Diabetic AL.
Chal. La.
Do we have supercross microcatheters?
No, we will have fine cross over here. And for Dr. Saito, we have something from Asahi, because we are.
And so with 15,000 of heparin, you don't check ACT. There's no need. You know you've
Now
got
at the end we will see. In
at
between,
the very
if the
end.
procedure is prolonged significantly, then yes.
Yes, exactly.
I can't afford to lose it.
It is in branch.
Yeah, that's why. Now go to epicaudal. Scout. Okay, that's right. So, one thing, we are so careful about all this, wire shapes and other things. Unfortunately, the art of angioplasty is gradually being forgotten.
Branch.
Yeah, because the science has advanced so much. The young generation is not giving that much attention to the art, I feel. And I am sure that these are very important things. Scout.
Yeah, absolutely. I think the whole concept of a pre-shaped wire is very counterintuitive.
It's okay. Yeah, Scout. So now I am more comfortable here. Okay, let it be there. Give me another wire.
No. Okay.
Another very important thing that Sanjay Bhai did, which was subtle but important, is while he was shaping the wire, he did not destroy the core of the wire.
Yes.
You were still able to torque it, which
During
was
bifurcation, I am giving this shape at the
You see?
end, so that I can recognize which is in circumflex, which is in LED. And we always put
You saw that at the end he has
Drape-
given shape
drape
for this
over the
circ
wire
wire,
so that
and he is
they-
putting a drape on this
so
wire.
crisscross never happens at the outside.
So you can't expect any intermingling of the wire.
It can happen inside, but not at least outside.
Even after the experience of 30 years, I have realized one thing, and doing more than 100,000 procedures, I have realized one thing, that not everything is easy at any stage. If you have to struggle, you have to struggle.
one of my teachers used to say an easy PCI is defined 4 weeks later.
Can you elaborate it? What do you mean by that? I want to understand that.
The patient has to be well and sitting in your waiting room happily. Then you can claim victory.
Scout.
My another teacher told that never think that it is very simple case, let us come and I shall do by few minutes. As because if your mind is set up as simple, when there is complication, when there is abnormality, anything, you will not be able to overcome. So everything,
one.
every case you
Keep it
will
there.
consider as
Okay. Go to epicaudal now.
difficult.
Law. Let us do the left main evaluation, OCT.
Okay. चलो फरी बार आना ना ओके सेट द प्रमाद और नीचे
बराबर દુખે છે સ્પાઝમમાં થોડું દુખશે હા બસ બસ રજનીના અંદર
ના પેલું ડોઝ રિપીટ કર દો હાફ હાફ
ડોઝ કર દો રિપીટ
No, no, no. Guiding is out. Guiding is out.
એપિકોડલ ઇન્જેક્ટ કર દો
ડાયલેટ કરીએ પછી કરીએ હોય તો આપણે
ડાયલેટ કરવું પડશે I think we
curvature is significant.
I'll try once by doing some changes in the coaxiality. If it doesn't work, it is all right. It's working little bit. It has gone.
Yes, yes.
Still, I am doing some change in the coaxiality. I think we have crossed the left main.
No.
No. અને આપી દો અહીંયા આવે છે gone. Yes.
You to just L6 osteum
Scout.
we are in. Okay.
Yeah,
fine.
yeah. A little bit more. It's okay.
It's okay.
Let us evaluate the left main.
Chal.
અપાઈ ગયું
બહુ પાછળ છે
But let us see if we get information. I don't want to repeat. If we get some good information.
bifurcation તો બરાબર
There's a lot of calcium.
Some blood, right?
બીજું લઈ લો બીજું લઈ લઈએ we take another one.
નહીં આવે સમજે કારણ કે it is obstructing. Calcium is becoming obstructive. You know?
છેલ્લે આપીશું
Okay. Sanjay has a technique. Again one more shoot. He will give very late injection. Yeah. Chal quick. Inject. This is beautiful.
Wow.
This is a late injection.
Great. Yeah. We could get that clear image now, right? Yeah.
It's a beautiful image.
Yeah.
Heavy calcium.
Lots of calcium, right? Yeah. Okay. So now left main, right? So try to find the distal. Here is in the distal LED here. When we try to identify here, we can identify the here is a CX. We can identify the wire here, right? Yeah. Therefore, I try to rotate. No. Right. Rotate. Yeah, setting. I'm sorry. Yeah, rotation right here to the 8 o'clock, around 8 o'clock. At that time, upper side is an epicardial side and the lower side is a myocardial side. So, and then yes, try to pull back from the distal, right? So the calcium is mainly upper side, right, at this portion, right? Very heavily calcium here. Right. Yeah, here is the left main. I try to measure the size, right, the length.
12.23, so it is a
Around-
little less than 4.
Around here. The EL is around 5 in this direction, right? And the yes, this direction I cannot identify the EL, but around 5 EL, but so right. And the distal portion, yes, you try to identify. Here might be the landing zone. Looks a little bit disease, but
બે વાર નીચે હવાનો પુશ કરતી પછી એકવાર આ કરો.
okay, right.
આ સીધો કરી દે સર.
I would like to say here is in the bifurcation, right? And and the CX size is lots of disease at the orifice of the CX, right? Yeah. Diameter is only right from here to here, 0.7 millimeter, right? Yeah. And here we have lots of calcium in the upper side here, and also the lateral side here, another calcium. But if you do the high pressure ballooning, we can expect the dissection, this portion, right? Yeah, deep calcium. Deep calcium, yes. Here is an media, right? In this portion, right? Some disease here, so simple dilatation may make some damage here, I'm afraid. So here is a huge calcium protruding.
This is like a calcific nodule. So this is not a great case even for intracoronary lithotripsy, and the balloon will not go the way I face the problem here. And my thinking in this case is I like to dilate it with a non-compliant balloon very aggressively. I know that my right is huge, and I also know that my left LAD is otherwise okay. Circ is again not a very big artery. If you know, and looking at all this calcified area around, I will like to avoid, at this point of time, even rotablator. I will go ahead and dilate this, and then we will see what happens.
Okay.
Just show me. We may take
Next.
I will dilate it with a 3 millimeter balloon, 3 by 12. 3 by 12 get me NC emerge, yes.
Dr. Patel, a prominent calcified nodule at the bifurcation site. Will you keep in mind using the IVL over here? Maybe after balloon dilation.
Samir and Elvin and others, what do you think? It's a complex situation, I know.
I think, any order is fine, but I agree with you that the IVL balloon may not cross the whole segment. So the first step has to be some sort of a trackable dilatation. NC is not a bad idea. Eventually, to get full expansion, you might need IVL anyway.
Yes, I also agree. And the question that I have at this point is, are we still staying on the strategy of a provisional?
Yes.
Just why not rotablation?
Rotablation, if at all, no reflow happens in this situation, we are in trouble. Scout.
Yeah.
Because once we dissect the balloon,
बराबर છે.
Here,
Okay, go.
can you see the OCT here?
Yeah.
Yeah. As I told you, this is an
Calcific nodule.
Nodule, yes,
Nodule.
nodular calcification,
15,
right?
20.
And if possible, we try to do the rotablator, but wire is here. If we think about the wire bias, rotablator is not so effective.
Yes, and see the balloon expansion with a 3 millimeter balloon looks good.
It is. It did open up pretty well.
See,
Yep.
there is some plaque shift at the circ origin. It's all right.
Yeah.
At this point of time, Dr. Akasaka, can you identify the normal area distally and proximally
Yeah.
and define
Yeah.
the length of the stent?
Okay. Right.
Yeah. I will not, because if I dilate it and if I have to recross or other issues, it will be a problem. So, and this is a calcified area, it is not a soft plaque. So there are less chances that it will completely occlude. So we will wait.
Wait. It might be difficult to identify completely
Yeah,
normal.
but this looks reasonable. There is some calcium,
Yeah,
a
some
good
calcium,
amount of
yes,
normal
it's very,
area,
very
and some
stable,
fibrosis.
stable,
Yeah.
Right. And
And-
yes, distal is here. Here is the
Ah,
distal
yeah.
yes, right. So
Dr. Patel, can we do the repeat OCT now to look for how much we have modified the calcified nodule? And
I would have done that, Rajesh, but
Yeah.
in the other lab, Dr. Saito is ready. So I will be stenting it, not because, and it should be okay, and then we will take a view. Yeah.
this is just proximal to the branch of the LED. The diameter is 3.1.
3.1 and distally it is somewhere in the tune of 4.
And the proximal is here.
Proximal.
Yeah, 3.8.
Less than 4.
Less than 4.
3.5 is a good bet for this.
Right.
And what is the length?
Length is, wait a moment. About 10, therefore 12 or
12 should be fine. Yeah.
12 should be fine.
3.5 by 12, and here I will use Giants Alpine. Calcified area, I need a great radial strength here.
This is an awesome demonstration of precise selection, and I think the orientation that Dr. Akasaka showed, where you put the side branch at 8 o'clock, is something that is not written in the books, or at least not noticeable easily. So for those who are new to imaging, I think it's an important thing to get an idea of what is epicardial and what's myocardial on the OCT image.
Calcium is okay.
Yeah, when you put back LED, we try to put the LCX around 8 a.m. 8 o'clock. And if you put back the CX, try to put the LED around the 3 o'clock. At that time, upper side is always epicardial side, and the bottom side is myocardial side. So try to do the, when you try to do the ablation using a rotablator or orbital atherectomy, it is very important to identify the distribution.
That is a very important pearl, I think.
Yes. You saw I had even difficulty pushing the stent, even though there was a lumen. So calcium, and particularly that nodule, is becoming obstructive. Samir.
Okay.
Yes, absolutely.
The stent was hitting little back.
This is okay.
That looks good. Yeah.
That looks good?
That looks good.
Yeah. So there is some haziness, but I have to go in.
Yeah, absolutely.
Out.
Right, that looks better.
Perfect.
It looks better.
Yeah. Go at, yeah, 10.
10.
Keep it there for some time.
This is a classic South Asian coronary.
Deflate. Yes, go. ठीक है भजन बा?
20.
18.
18.
Deflate. Chalo, I pray God that this is expanded well without doing much to the circ.
The balloon looked well expanded.
Good.
There is a,
Proximal
yeah.
LED.
That we'll see. Now, first thing I will do is I will run a OCT here and I will continue working here, and we will switch over after OCT to Dr. Saito's lab because he is there prepared, and he has been my guru, teacher. I don't like him to wait. Yeah, but we will then come back with the result, no problem. I tell you, the distal area, it looks very hazy, but it will not look as bad in OCT. I know that. Because of the calcium, it looks so bad. And I would have perspired at this point of time without OCT imaging if I am doing this case. Because then I am not sure.
Makes you feel bad for yourself for all these years when we did not have imaging, didn't we?
Yeah, I think so.
We sweated so much more than we needed to.
And this has happened like, Samir, what we used to do in initial stage, and we used to, afterwards the things improved, and we thought that what were our seniors doing? And our young generation will also say that what was Tejas Patel doing? He was doing something rubbish. Yeah.
Fine.
Okay. Fine. Yeah. So that is advancement in the technology. Okay, go.
Okay. Chal.
Chal bhai. Again a late injection he did.
Yep.
Very beautiful image. Right?
This technique Rajiv works, late injection, yeah, because that gripping will go slowly behind. Look at this. Samir, now what do you say? Elvin, what do you say now?
Looks very good.
I'm waiting for the circ.
My funda is very clear, Elvin. Even proximal we have to do pot.
Distal D.
Distal D, let me see.
Small dissection.
It's small, yeah, it is intimal, so no problem.
No problem. Right.
This is neglectable, yes.
And the position is okay, right? Great. And yes. And here is right. Calcium. Might be CX is here. Another wire coming, right?
4/8.
The proximal small incomplete position, right? Because the vessel is not round.
Calcium.
Yeah.
So here again I have one hesitation to go at a very high pressure with 4, because if I break the strut, I am giving 100% restenosis at that point. So I will be very careful. If I am using a 4 millimeter stand or a balloon, non-compliant, I will go at around 10 or 12 atmosphere and not more than that. Again, I need your feedback on this.
I think that'll probably work. What about the very ostium of the LAD? Right before the circ ostium, you see a little bit of a negative lumen there in the stented area. Would you flatten that out with a 3.5 at higher pressure?
No.
Tej, will you rewire the circumflex before you pot, or you'll just pot now?
I will pot first, because rewiring, it may go behind that area. That's a problem.
That's a very good decision.
Left main is 5 millimeter in the OCT.
No. Left main, the proximal area, Professor, 4.6? 8. It's okay now. Proximal area is somewhere around 4.2.
Okay. And do we have enough landing zone for
4,
the
not
pod
even
balloon?
less than 4.
Here is the proximal landing zone. At the moment, the diameter is
Epicranial?
3.9, but as you may know, here is some, not a circular of the left main, right? Some incomplete position in the...
Look at this. Samir, look at the LED now in epicranial view.
Yeah, it looks very nice.
So that shadow what you see in caudal view is calcium accumulated at one side.
Absolutely. And it's a diffusely diseased vessel, so it's never going to look...
So we have done so much of disservice to our patients in past, in this type of cases, if I think retrogradely.
That's true. We used to overstent because we wanted to see better lumen angiographically.
Professor Akasaka has been our mentor for OCT imaging. He came here before maybe 3.5 years, and since then, we have never looked back, and almost now more than 1500 runs of OCT we have to enrich our experience, and more we do, more and more we are convinced about it. Yeah, Scout. Looks good, Sanjay?
Okay, little more. Okay.
Looking at the size of this circumflex, I think that I just want to ask the opinion of the other moderators here. Who would really go and take the effort to do a kiss or say we accept this?
Go.
It's a right dominance, clear right dominance, and they just fix the right.
I think the right PL is huge, so I would personally leave it alone.
And I tell you, Elvin, it is a half a vessel or 3/4 vessel disease or maybe one vessel disease. Even if patient has some angina, medical management, excellent prognosis, if this both stents survive. This is what is my thinking.
Yes, that's what I'm also thinking, because looking at that,
Super.
you will not make it better.
Yeah. And you will unnecessarily damage, those areas in the left main which are seated in a very heavily calcified area and calcific nodule. If you do some damage there, unnecessarily we are giving higher chances of restenosis in that region, which is a very vital region to continue life for the patient.
I think, another finding which we can see angiographically is after part, the circumflex actually got better. You can show it in the past few views and then the latest view.
Do you think we can do one more IVUS run?
It might be okay, yes.
Circumflex flow is also very good, TIMI3 flow.
We can give some nitroglycerin, and by the time IVUS preparation, and then we switch over to Dr. Saito within 5 minutes.
It's always like this, in fact. After the pot, the sided branches always get better. I don't know the mechanism, but it's something I see often.
I think according to Dr. Luard's explanation is resetting of the carina. It's way beyond me geometrically. I just like the terminology.
I tell you, Samir, our understanding of bifurcation has been enriched by Yves Luard. Yves has been a very great friend, and he has attended so many tricos, till he retired, and I still, love his thoughts on bifurcation. He's the one who made it so simple.
Absolutely. The only thing, the caution about Dr. Luard is you cannot go home and do what he does because he makes it look very easy.
Okay?
Still little.
Okay.
Fine.
Okay, now we go ahead with a IVUS run, and again Dr. Akasaka will give commentary on IVUS because he has, been an equal expert for both this imaging.
Yeah, this is a distal part. Yes. We can identify the calcium at 9 o'clock and 3 o'clock, right? And this is a plaque, yes. I cannot identify any stent slot at this portion, right? Then coming a branch, right? Another branch, right? Here is I can identify the stent. Yeah, a position is very good by IVAS, and also the size is okay, right? And yes, here is the disease portion, I'm afraid, right?
Yeah.
Yeah.
Calcific nodule.
Yeah.
Plaque burden, eccentric plaque
yes,
burden.
yeah.
A huge plaque burden there.
Yeah, we can identify another wire coming here, right?
Yes, yes.
The left main. So
how do you decide, Dr. Akasaka? Very important question which I am still not able to understand, and even Malcolm Bell last time told. How do you decide proximal and distal crossing by examining, IVAS image?
IVAS image.
Yeah, you and Dr. Saito were discussing last time. We remember distinctly.
We cannot identify the condition precisely by IVAS. OCT gives us the stent strut condition and wire condition very well. So I prefer to use.
But still, on this, what do you think?
Okay. Right. Here.
It's a jailed wire, I think.
Yeah,
Yes,
yeah, it's a jailed wire. Yes.
Yes, yes.
Yeah.
So we can't see that.
Akasaka is behind.
Here's
Where the
the-
stent strikes, so nothing to worry about.
Let us take the final views. So, I know there may be the difference of opinion, and the other end may also be right, but I will love to leave her at this point of time. Particularly, see this, here you see that there is a haziness, there is dissection in the distal area, and now I will show you epicranial view. And you see how it looks.
Very good.
So, here I like to end this case. Thank you very much, and we are switching over to another very complicated, interesting case to be done by Dr. Saito. Thank you.
Patel, for your excellent case.
Great case.